what has been missing for all these years is a way to bridge across the translational gap. So we have tons and tons of new discoveries about aging, what drives aging. We can even reverse aging, at least in the laboratory. But that hasn't really translated to humans at this point. And so
no, I'm waiting.
Our focus is to think about how we're going to do that.
And do your plants age too?
Do plants age? I am certain that they do.
Sorry for Saying Sorry Media presents the Purr Podcast, the best podcast for feline medicine and surgery with tips, tricks, and updates for the entire veterinary healthcare team. If you're dying to know more about cats, keep on listening. Here are your hosts, Dr. Susan Little, famous cat vet and textbook author, and Dr. Jolle Kirpenstein, talented surgeon and social media geek.
Hi, this is Dr. Susan Little.
And Dr. Jolle Kirpenstein, and this is the Purr Podcast live.
Japan version.
Tokyo version. Although we shouldn't say that much because it might be a lot later,
Well, we're still in Japan.
Yeah, we are in Japan.
It doesn't change that.
Japan. And this is our fourth guest, Japanese guest.
Yes, well, not really a Japanese guest, though, right?
Right.
Unless there's something about you we don't know.
Yes.
No.
You don't have
Japanese descent.
No, nothing.
No. So it's the fourth interview we've recorded in Japan, and we're very lucky to have with us
Nicole Earhart. Hello, everybody.
Hello, Nicole. So what do you do, Nicole?
I am a surgical oncologist at Colorado State University, professor there, and also I direct the new Center for Healthy Aging at CSU.
Wow.
How old is the Center for Healthy Aging?
Great question. It is physically about 2.5 years old, but this is the first full-time director they've hired, and that position started on August 1st.
So what does the Center for Healthy Aging do?
Well, what we are doing is creating a transdisciplinary or interdisciplinary research center that will unite different areas of research involving aging across campus at Colorado State University and then among different universities with an emphasis on comparative medicine. Comparative medicine is a wonderful way to think about aging research in a new way. People haven't really been thinking about aging research as an aspect of comparative medicine. So it's a new model, and it's something that I think is really exciting.
And we all age.
Yeah, we all age.
Is
this multiple species or just certain species?
Multiple species, and so really thinking about the companion animal in any sense, whether that's horses, cats, dogs, bunnies, whatever, as a means to think about animals that age in a natural way, rather than thinking about laboratory animals of aging, although that is still a very important piece of aging research. What has been missing for all these years is a way to bridge across the translational gap. So we have tons and tons of new discoveries about aging, what drives aging. We can even reverse aging, at least in the laboratory. But that hasn't really translated to humans at this point. And so
no, I'm waiting.
Our focus is to think about how we're going to do that.
And do your plants age too?
Do plants age? I am certain that they do. But probably
everything ages, doesn't it?
Yeah.
I think there's
different
probably
maybe
things
different
that are
rates or very slow.
Yeah.
Right?
I'm not totally sure.
Some of them
because
live
some plants are really
long
old.
time.
Some plants are very old.
So what got you interested in that?
Yeah.
Yeah, that's a really great question. So I was doing some work in stem cell research in muscle regeneration and bone regeneration, and started realizing that as we age, our stem cells in our body, which are our repair mechanisms, they'd begin to diminish in number, and the function gets messed up. And so as I thought about how to regenerate tissues, it sort of morphed into not only just regenerating tissues and big tissue defects, which is really where I started this research, but also thinking about how we can help our muscles and skeletal system age in a more healthy way. And so that, when I say our, I mean humans, but also companion animals.
Because there is some interest in stem cell treatments for things. Like I know Colorado State's been doing some work with like kidney disease, for example. And I know there's also interest in stem cells for things like arthritis too. And
that is correct.
In a way, to me, it seems like to some degree, what is happening out in clinical practice is a little bit ahead of the science or the evidence behind it. Right?
I think that's a great summary.
Way of putting it?
Yeah, I think the hype has been far ahead of the science. And so people have really jumped on the bandwagon on the promise of stem cell therapy, but the actual evidence is less than maybe what one would think for the various ways in which stem cells are being used. That's not to say that there isn't enormous potential, and that in certain circumstances stem cells can be an amazing treatment for many diseases, but I think the way in which they're used currently can kind of dilute the evidence that they're, that they potentially could have to support that.
Yeah, because we don't have really evidence-based protocols. And when you say stem cell, right, it sounds like it's a thing, but there's like different types of stem cells and how many injections and how do you deliver it. It's pretty complex, huh?
It is really complex. Yeah. And, as we age, the stem cells themselves, so all of our tissues have stem cells, but as we age, that stem cell number diminishes and the function of those stem cells diminish, and that whole process is a driver of aging. And that it's called stem cell exhaustion. So one of the things I was working on is, can we reverse stem cell exhaustion using various types of biologics? And the truth is, at least in the laboratory, we are very successful at that. And I think it holds a lot of promise for companion animals and humans. But right now, we need to translate that effectively. And to this date, it hasn't been done very well, but I think we have an opportunity, especially using comparative medicine, to do that.
And in your other background is in oncology,
yes,
where
sir.
stem cells play an important role too.
Yes.
It might be the other side of the coin a little bit, because when you talk about stem cell therapies right now, people also talk about, what happens if these stem cells go away, and then you get tumor formation again.
That's right. Yeah, so there is sort of a dark side of stem cells, and that is been shown over and over again in laboratory studies that if you inject tumor cells along with stem cells, it actually promotes tumor growth and promotes spread of tumors. And so we were really interested in that question, is how safe are normal stem cells in cancer patients? And we did some work with that, specifically using a model of osteosarcoma, and learned that I know, it's my favorite tumor too,
that's a
in a weird and terrible way.
Yeah, I'm not sure.
Is that not good?
It's like a bit of an oxymoron or something.
A favorite
isn't it?
tumor.
Yeah. But I say that I have favorite diseases too. It's kind of the same thing. So,
I know.
Yeah.
Anyway, so we found out that if you give the stem cells locally in the site of a previous surgery, it actually didn't have any increased risk of promoting recurrence of the tumor, even when we knew there was microscopic residual disease. But if you gave them systemically, if you gave them in the circulation, they lodged in the lungs, and in animals that had pre-existing microscopic pulmonary metastasis, it actually promoted tumor formation.
So it varies from tissue to tissue.
It varies in the delivery mechanism. Yeah, so there's a lot out there. I mean, I could have, a 2-bottle of wine conversation with all of you about stem cells and the good, the bad, and the ugly.
Yes.
Yeah. And it's this bit that worries me a lot when we see, companies promoting stem cell products, and you think, do we really know enough to be out there doing that? Yeah.
And that's why we need this research group that has a little bit more emphasis on especially the evidence base behind it.
Right. And safety.
And safety. So as a surgical oncologist, what do you do?
Well, we're mostly focused on removing solid tumors in a way that promotes the optimum treatment pathway for those pets. So cats, dogs, occasionally other creatures where we that have cancer and need to have that cancer removed surgically as part of a multimodal treatment plan. So we work very, very closely with our medical oncology group, our radiation oncology group, and even our clinical trials team to determine an optimum treatment pathway. And that is a conversation that happens long before the animal ever goes into the OR. And we feel that this multimodal approach, this way of looking at cancers from multiple different disciplines, is the best way to think about treating cancer, and has certainly shown benefits in human medicine, and we see this also in veterinary medicine.
And can you tell a little bit the role Colorado has played in this? Because I think Steve Withrow is, we always call him the grandfather of oncology in general, surgical oncology in specifics. And he came from AMC, came to Colorado, and that's where he started this multidisciplinary system.
Yeah, and he really was a visionary in a time in veterinary medicine where cancer was almost a, diagnose and euthanize kind of situation. And so he and along with Ed Gillette and other pioneers really started this comparative oncology program, which is very, as you can kind of tell, echoes sort of my own approach to aging. But Steve has been a pivotal player in this whole concept of multimodal cancer therapy. Colorado State University was one of the first universities to have an integrated clinical oncology service where when clients would come in with their pets that had cancer or were suspected to have cancer, they met with a surgical oncologist, a medical oncologist, a radiation oncologist, and a clinical trials team member, all in the same day, and typically at the same time in the same room. And we found that just even hearing each other talk, the radiation oncologist, the surgical oncologist, the medical oncologist, the conversation that happened helped us to really fine-tune and adjust and make little tiny course adjustments in our treatment plans that really gave the animal the best potential outcome. And that's been shown in multiple other situations. When you have a complex disease, if you have multiple specialists that are talking to each other with either the patient or the client, in the case of veterinary medicine, in the room, the outcomes for those patients are so much better. And I can see why. I mean, this has been something that I sort of grew up in, was immersed in, and I think I'm a believer. And certainly Steve has been an amazing influence in my life and many people, including your own. I know,
absolutely.
Jolle, and just pioneering this whole approach.
And that's quite a shift in veterinary medicine, as you say, right? In not that long a period of time, right? Because I don't think we've been paying that much attention to oncology and veterinary medicine in length of time compared to the human side. So, comparatively, I think we've gone a long way from, just within my career, right? My professional career, all the way from, it's got a tumor, sorry, right? To now we've got these multidisciplinary teams that get together.
The interesting thing is that in my career, I haven't seen that many other entities do the same thing. So
yes.
You probably should do the same thing when you're talking about kidney disease, and you probably should do the same thing when you talk about heart disease. So you get all those different opinions in there. The one thing that I remember from Colorado when I was there is that you had the rounds where the students were there, but it was not only the students who were the internal medicine, radiation, pathologists. They were sitting there and discussing. And Barb Powers is the pathologist of the century, and she was there, and she was always open to listen to you and give opinions and that sort of thing. So it was just an amazing experience, the good and the bad. I've cried so many times during those stupid rounds because of those cases and those stories, and that it just brings that group together, and it's amazing what you can do.
And it's an amazing training facility too for residents, whether they're surgical residents or internal medicine residents or oncology residents, because all of a sudden they're hearing the surgeons talk about what they're concerned about, what they feel is going to be successful, and they become better educated about the surgical options, even though that's not their specialty. And so then when they go elsewhere, they can have an initial conversation and say, I'm not the surgeon. Because often what happens is pets will see, owners will see a surgical oncologist or a surgeon, and then in a different day or a different appointment, they'll see the medical oncologist or the radiation oncologist. And it gives them an opportunity to really see the whole treatment, seeing the holistic, I guess, treatment of the pet, and gives them a lot more perspective. It certainly has for me, like you were saying, with the pathologists. My goodness, I mean, just understanding just the difficulty of interpreting margins, interpreting specific histologic sections, and how they make those decisions. Really helped us understand a lot more, I think.
Yeah.
So why surgical oncology? So did you come at this from an interest or a passion in surgery, in oncology? Was it both? Did you always know you wanted to do this? How'd that happen?
Good. Such a good question. So I've always sort of had an interest in human cancer medicine since I was in college, and more from the perspective of, I guess, kind of the human-animal bond and how animals could serve in patient situations with therapy animals and that type of thing. That was a big deal in college for me. I started a pet visitation program at the Ronald McDonald House in Philadelphia when I was at the University of Pennsylvania, and became interested in surgery throughout my vet school career, and then received a surgery residency at Colorado State University, and that is actually where I met Steve Withrow. The story, though, about how I ended up being a surgical oncologist, I actually started my surgical career thinking I wanted to be an orthopedic surgeon.
Oh, really?
I know. Hard to
Confession
believe.
here,
Yeah,
right here.
right?
It's like that's like a completely different geography, right?
It is.
Yeah.
It is.
It is
Different
but it's
personality.
Not. But because now I understand with Steve, it's not. As a matter of fact, and you will get this from the story. I guess.
Yeah, so I thought that I wanted to be an orthopedic surgeon. I also thought I wanted to go into private practice. I thought, no way am I ever going to have an academic career. Those guys have to work way too hard. They make too little money. And so anyway, I was, I think, a first-year resident. I was in the OR doing something, and Steve Withrow came crashing into the room like he usually does and said, Earhart, we need you at cancer camp. And I said, what the heck are you talking about? What is cancer camp? He said, show up at this place with a canoe paddle and a sleeping bag or something on this day, and I got you off clinics. And I went, yes, sir. And like a good little resident. And sure enough, I showed up at this cancer camp, and it was a summer camp for kids with cancer. At the time, it was run by Ronald McDonald House. And it was kids from ages like 8 to 16. And they needed a lifeguard. So he had looked on my CV and saw that I was lifeguard certified. And so he just recruited me, like literally commanded me to show up there. And I met a little girl, and she was 8 years old. Her name was Jenny, and she had an amputation. And she was only about 8 weeks or 9 weeks out from her amputation and already swinging around on her crutches and things. And and she was bald and had been on chemo and stuff. Well, at that same time, right before we had attended camp, I had been listening to lectures on limb salvage in dogs, and just learning about how we were saving the limbs of these dogs that had bone cancer. Turns out this little girl also had bone cancer, and as many of you know, bone cancer in animals is exactly the same as it is in people, especially dogs. In fact, if you look under the microscope at a tumor section from a person versus a dog, you can't tell which one came from which. And they behave the same way, and they're treated the same way. So I thought, man, now that's so weird. We're learning how to save the legs of dogs, and here's this 8-year-old child who doesn't have a leg. And she had a lot of challenges. In fact, I remember one particularly funny day where we were trying to figure out how you pee in the woods with only one leg.
No.
It's very difficult to do, especially as a girl.
Female.
Yes.
Oh.
So, I mean, it was just so impressive. But you know what impressed me the most about this child was her spirit. And she was so inspiring, and it was one of those, you have tipping points in your career, and that was a tipping point for me. I said, you know what, I have no business going into private practice when there's a lot of work to be done. And I went back to my job and walked into Steve's office and said, hey, I want to dedicate my career to figuring out how to save the legs of kids and dogs. And and so that's what basically started my career path. And it was it's one of those things that I have to this day. I still go back to that camp every single year. I think it's been 30 plus years, and I bring my residents and graduate students there, and I share with them. I say, I want you to look into the faces of these kids. I mean, they needed help yesterday, and it's going to take all of us working together to get to a place where we can really make a difference. And you may think that working in the lab counting cells under a microscope or checking, this or that is really tedious, but I got to say, this is why we're doing this. And
where can people find more information about this camp?
skyhighhopecamp.org.
We'll put a link in our on our website and our show notes.
We do take volunteers. We have 100% volunteer staff. The camp has been running for 30 plus years. Is now under the auspices of the Limb Preservation Foundation, which is a nonprofit dedicated to education and patient assistance and research in people that have limbs at risk of amputation. And I happen to serve on the board of that organization as well. So plug in for those guys.
Yeah.
They're doing really good work out there.
And I remember when I was there was such a close connection with the human oncologic surgeons that did osteosarcoma and Steve's group. Steve helping them out and them helping Steve out with these amazing kids and also these amazing dogs, that animals that come in that people are so attached to. They're not ready to give up. So dedicated. I mean, I've never seen more dedicated people than at Colorado State. I think driving from Florida to Colorado to get their animal treated, but also novel things that were developed at CSU that were tried in people and got exception to be used in people. It's just amazing.
Yeah, I think Steve pioneered those relationships between veterinary surgeons and human surgeons in the cancer world, and To this day, the sarcoma surgeons, the people that do limb salvage surgery in people, they know his name, and everybody knows his name, and he has really set a bar for others, and they're very aware of the power of comparative medicine as a way to advance surgical techniques, cancer treatments, and now aging. This is the newest area.
Good One Health example.
Yeah.
Right.
It's really great, and I think it's a lot of veterinarians are aware of it. On the human side, I think in some disciplines they are aware of it and using it, but in a lot of disciplines are not.
So true. Yeah, and I think that's true in the aging space until very recently. So that's one of my big missions, is kind of spreading the word. And but yeah, I think that even in the surgical fields, the spine surgeons have never heard of this kind of thing, for example, whereas the sarcoma surgeons are very familiar with it. So there's still a lot of work to be done in raising awareness of one medicine and comparative medicine as a powerful tool to translate new discovery to people and to pets.
Yeah, we even have MD DVMs now in the limb sparing arena. I know Will Ewart, who is a wonderful doctor, both human medicine and veterinary medicine, and I think he does 4 days of human medicine and 1 day of veterinary medicine. It's amazing, if you think about it, and he brings things into both arenas that he learns. So it's just that's very empowering, I think.
Let's shift a little to feline. Yeah,
we did say the D word.
We did.
Yes,
we need to inject a little feline here.
Okay.
We can talk about feline bone tumors a little bit. What's the difference between the D and the cat?
Well, feline osteosarcoma, the most common bone tumor that we see in both species, is a very different kind of disease in cats, in the sense that it's less aggressive metastatically. Right. So it tends not to spread quite as quickly. And although it can spread, and oftentimes if we catch it early, amputation can be curative. And unfortunately, that's not the case in other species, but we're really lucky with the cat. The cat is one of those species where we can do a lot to improve quality of life. The other nice thing for kitties is that they do extraordinarily well with amputations. They never look back. Yeah. And so for us, when we have to perform an amputation, that's always a loss to lose a limb, regardless of who you are, four-legged or two-legged. But certainly cats seem to adjust extremely well. And
at least one example of where cats do better. Not a lot for poor kitties, but that's one good example of where cats do better.
I've seen cats with 2 legs that are without any problem.
3 is easily no problem. There's lots of tripod cats out there. What's the most common tumor surgically that you get called to treat in cats?
In kitties, it's probably squamous cell carcinomas. Yeah.
We talked about that today.
So Jolle and I did an oncology talk this morning, and we talked about oral squamous cell carcinoma, and we talked about it in the context of my own cat who was diagnosed with an oral squamous cell carcinoma. And we did talk about that multidisciplinary approach within veterinary oncology. So my cat had surgery and radiation and chemotherapy. And so I think that's an important point to make, that not all, and maybe the minority of tumors can be treated with like one modality, right? Yeah. So.
Well, I'm sorry to hear about your kitty. Yeah, and squamous cell carcinoma is very frustrating in the sense that, especially location-wise, it can really change its behavior. So under the tongue is probably the hardest one, or tonsillar. And we do see squamous cell carcinoma a lot in Colorado in the skin of cats because of our high altitude and the UV exposure. So light-colored cats developing little crusty lesions on the edges of their ears or nose, that's something that you certainly want to have checked out, because the earlier we can catch a very small squamous cell carcinoma, just like in people, the more likely it is that we can get rid of it with the surgery and hopefully not see that disease come back.
At least that's in a visible location, right? Like owners might not know the significance of it initially, but at least it's visible. I think the challenge with the oral ones, of course, is that by the time you find them, they've often been there quite a while. I
know, and since cats don't pant normally, owners don't see inside their cat's mouth. So until there's either a visible swelling or some blood in the saliva, or
my cat was drooling.
Yeah.
Here's my cat owned by 2 veterinarians. right? And it wasn't until the tumor grew big enough that he started to drool that we realized.
I think the thing that's amazed me so much was the fact that the cat had lost 1 kilo, and you two had no idea that it did.
Yeah, he'd lost about 10% of his body weight by the time, we were suspicious and took him into our clinic and whatnot. And it really highlighted for me how challenging it is for owners who see their cat every day to appreciate slow, gradual weight loss, right? Because I used to think you get an owner who comes in with a cat, whether it has cancer or some other disease, and you weigh the cat and it's lost, 1 kilo, and you think, well, how did you not notice? Well, now I know.
Yeah.
If it happens rapidly, you notice. But now I know exactly why you don't notice.
I know. We see that often living in a college town. Students that are away for a semester and then come home.
Yeah.
And notice that their pets are something's very different, whereas the parents who have been with the pet every day don't notice it.
Yeah, it's too slow and too gradual. And so, there's another pitch for regular preventive healthcare visits, right? And monitoring weight in cats.
Especially in cats, because we do know that most tumors that are in cats are not so good.
I know.
Yeah, they have a higher percentage of the bad stuff.
Yes.
Yeah.
So really when they don't get tumors that often, but when they get them, they're bad.
Yeah.
And so you need to be early. And we often laugh about it as surgeons, like a chance to cut is a chance to cure.
But
always. Surgery is very often, if you do it early, a curative treatment modality, and all the other ones are not. And so it is important to do preventive medicine. To at least when I was still in clinics. I had clients after the cancer diagnosis come in every 6 months.
Because now they're very hyper aware.
And so people were like, why are you watching those cases? I mean, they're all normal. I mean, I got case after case after case coming in the clinic. And at first it was because of the relationship with the client that you have, but second, because of preventative, because I want to catch them early. I mean, you only get one chance.
Yeah, it's so true.
Nicole, this was wonderful. I know this is the first part of our 2 series, Surgical Oncology. We have still lots to talk about, so thank you very much.
Oh, I can't wait to talk some more with you. Thanks for having me.
So you'll be back in 2 weeks, I guess?
Yep. We'll have more surgical oncology in just another episode.
And is this the first surgical oncologist
that we have?
Good question.
Other than you?
Yeah, no, I don't count.
Because he doesn't count.
He counts.
Well, he counts. Well, we don't let him talk about surgical oncology on the podcast. I think you're right. I think you're our first surgical oncologist.
So exciting.
So honored.
Yeah.
Thank you.
Yeah.
And then we should not forget, you can find all the information on our website, purrpodcast.net.
Yep.
And what do we have to do? We have to subscribe.
Yep. Please subscribe, and hopefully you'll give us a good rating. And you'll also find us on social media at Purr Podcast on most social media channels as well.
So thank you so much.
It's a pleasure. 5 shiny stars for you guys.
Thank you.
Dr. Susan Little is a feline medicine specialist with 2 cat-only hospitals in Ottawa, Canada. She is best known as an international speaker and as the author and editor of 2 textbooks, The Cat, Clinical Medicine and Management, and August, Consultations in Feline Internal Medicine. Along with 3 cats, she also admits to owning 2 dogs, and you can follow her on social media with the handle @CatPetSusan. Dr. Jolle Kirpenstein is a diplomate of the American and European College of Veterinary Surgeons and a big cat fan. His specialties range from surgical oncology and reconstruction to minimally invasive surgery. He is the author of 2 textbooks on basic and reconstructive surgery. Did you know he was allergic to cats? Jolle works currently at Hill's Pet Nutrition. You can follow him on social media with the handle @GVETSX. This episode is made possible by the generous sponsorship of the Take the Pledge Against Struvites in Pets Facebook page. Did you know there are 3 easy steps to treat bladder stones in cats with lower urinary tract signs? Step 1 is to take a radiograph, and if there is a stone present in the bladder, step 2 is to use the Minnesota Urolith app for iPhone and Android to determine the most likely type of stone. Step 3 is to treat the cat for at least 2 to 3 weeks with an appropriate diet and see if the stone gets smaller. If so, keep feeding that diet until the stone is completely gone on follow-up radiographs. If not, check compliance with the owner and look for alternative treatment options. Join veterinarians worldwide to take the pledge not to remove struvite stones by surgery anymore. The opinions of this podcast are those by Dr. Susan Little and Dr. Jolle Kirpenstein. Veterinary medicine is a complex profession, and often there are multiple diagnostic and therapeutic options for different disease processes. If you're a pet owner with questions, please go to your local veterinarian. If you're a veterinary professional, ask your questions on our Instagram page @Purr Podcast.